Welcome to the AOA podcast series on lessons in leadership. My name is Ann Van Heest, and I am honored to serve as the 2023-2024 AOA president. As we discussed in our August podcast, part of my AOA presidential duties include joining the orthopedic carousel of presidents from 5 English-speaking countries and attending each of their annual meetings. One of the annual meetings that I'm excited to attend is the New Zealand Orthopaedic Association meeting in Nelson, New Zealand from November 4th through 7th. I am pleased and honored to have the New Zealand Orthopaedic Association president, Dr. Haemish Crawford, to our podcast today. We will be discussing lessons in leadership from his vantage point. Welcome, Haemish.
Good morning, Ann. Thanks very much for having me on the podcast.
So the AOA is a leadership organization, and as we discuss lessons in leadership, we learn so much from leaders of other countries. The diversity of our profession includes the diversity of orthopedic surgery in all these other countries of the world, so we can compare and contrast to our own. So can you tell us a little bit about the New Zealand Orthopaedic Association?
Thanks, Ann. Well, the New Zealand Orthopaedic Association was formed over 50 years ago now, and in fact, my great uncle was one of the founding members of that. And it's an association that we've been incredibly proud of. It has 100% membership of our orthopedic surgeons. It relies heavily on volunteers within the association to contribute their time to running it. And we also have a full-time staff of about 8 workers now who have really been very loyal to the association and really forms the hub of the work that we do.
How many orthopedic surgeons are there in New Zealand?
There's approximately 400 orthopedic surgeons who are part of our association now.
And does your association include ancillary orthopedic providers or resident and registrars?
So the registrars or residents, as they're known in North America, are able to be affiliated members. So they're involved in all our communication and to be heavily involved in the annual meeting and association affairs.
And do you include your physiotherapists or other extended providers?
No, so no allied health professionals are members, but we do welcome them to come to our meetings as affiliated members.
So tell me a little bit about your upcoming meeting and maybe about the subspecialty societies in New Zealand.
Yep, so we have subspecialty societies like all the associations, and we think one of the important strengths of any association is to have all those subspecialties part of the association rather than independent. So this has been something we've really worked on in terms of our sustainability, is to make sure the association really represents everyone's needs of our members and keep everyone united within the association. In that regard, this annual meeting is going to be slightly different from previous annual meetings. We've found that there has been a slight drop-off in people attending the annual meeting because the societies don't see that it really fulfills their needs in a meeting. So for the first time this year, we've shortened our annual meeting to the Monday and Tuesday, just 2 working days. And in the weekend preceding this, we have 2 society meetings occurring. We think this is going to serve 2 purposes. One is that some people who don't want to spend 4 days of a working week away from home at an annual meeting may just come and spend the weekend and the 2 days. Some people may just come for the weekend, so there'll be some overlap between those coming to the meeting and societies. But hopefully it means that we can have both collegiality, celebrate what we're doing, as well as a learning environment that fulfills the ongoing medical education for those subspecialty members, but also for the general orthopedic population.
Yeah, I think that's a leadership challenge, but also a challenge as an orthopedic surgeon in a subspecialty area as to which meetings to attend and how many meetings to attend, and to make sure the meetings that we attend have value.
I think you're absolutely right. So in terms of value, you need to ask the subspecialties, what do you want? And I think in terms of education, that's up to the subspecialties to provide the education that their members of their society want. But if you look at an association, what we provide more is the training of registrars, the advocacy with the health authorities and the government, the interest groups like for New Zealand we have the Indigenous or Maori members who have their own society as well, and our Lions or Ladies in New Zealand Orthopaedics who have their society, and so we can as an association address all those other really important issues or pillars that's important, and that helps all those subspecialty societies. So, correct me if I'm wrong, but I think that's been done very well in North America, where the Academy has fulfilled some roles, especially in education. The AOA over the last number of years has taken a slightly different direction in terms of addressing those other really important issues, and also leadership and accreditation.
Yeah, and certainly one of the things we have is the AOA includes the residency program directors.
Yeah.
Where do they fit in the New Zealand system? Is there a group for all of the training programs to come together and talk about education issues?
Yeah, so that's not done at an association level, but that's done at our Royal Australasian College of Surgeons level. So we have a college which is based in Melbourne, Australia, but also has a presence in New Zealand. And that has a specialty orthopaedic training board. So we have two committees for our training. One is the training committee, which concentrates purely on the education of residents, and then we have an SOTB, or Specialist Orthopaedic Training Board, which is the group that liaises very closely and in fact reports directly into the College of Surgeons, where they address the issues of selection, accreditation, and any issues in terms of that registrars have that they want to appeal any disciplinary action or want to take any action against the New Zealand Orthopaedic Association, so they can actually do that separately to having to come straight to us.
And are they part of the examination process as well? Do they run the certifying exams?
Correct. So the Part 2 or College of Surgeons diploma that we get, the FRACS, is awarded by the College of Surgeons, completely independent to the New Zealand Orthopaedic Association. However, we provide examiners to that college.
Yeah. And it's the interplay of these multiple different organizations across the country that can be a challenge to unify all of the different missions and objectives of the different organizations.
So you're right. So when So and my great uncle helped form the New Zealand Orthopaedic Association, there was no subspecialty groups, and the College of Surgeons looked after plastic surgery, orthopaedic surgery, general surgery, urology, etc. But now if you go down that sort of hierarchy, you can see that if you're in the Hand Society in New Zealand and you pull out of the New Zealand Orthopaedic Association, you've then got to form a way of getting back to that college in terms of how you run things. So that's where I think an association allows all those subspecialties just to get on with educating and doing what they do so well, and us having to do all that other negotiation work.
Well, moving on, as a leadership podcast, I am interested in your journey to becoming president of the New Zealand Orthopaedic Association. Can you tell us a little bit about your journey and maybe any tips that you might have for our young leaders?
Yeah, well, at the end of the day, I think everyone's a leader in some way in their life. They contribute, and everything you do every day, you exhibit leadership in making decisions and people watching that. I've never actually ever aspired to be a leader in any form, and I've been lucky enough to achieve a number of leadership positions through my life that has shown me the importance of being a good leader. From school days through to when I go to university, I joined the reserves to help pay my way through university, and was lucky to do my officer training through that and becoming an officer in the New Zealand Army. And that actually was probably the foundation that taught me a lot of leadership and a lot of respect for leaders. I've subsequently just been someone who's worked hard. I've been brought up in a family that has really driven serving the community, and in fact, when I finished orthopaedic surgery, did my fellowship, I think someone who's been really instrumental in that is Stuart Weinstein in Iowa, where I did my fellowship, and I look at someone like Stuart and a lot of the members of that Iowa orthopaedic department, and just seeing how much they have contributed to orthopaedics in North America. And
so it sounds like one of the facets of leadership would be mentorship.
I think mentorship in terms of observing what other people do and have people encourage you but not tell you what to do is important. So I've always struggled a little bit with appointing mentors because I think you find your own mentors in your own way, and I think I look at a lot of amazing people I've worked with, both within medicine and outside, and I don't always want to be exactly like them, but there's facets of their life and the way they work and their family life and what they do outside of work as well, which are really important, and trying to work out the balance that I want and the leadership style that I think is important, how they manage people, how they manage their work, how they treat patients. So, but yes, I think the importance of being a mentor without necessarily being labelled a mentor is just how you respect people that work for you and how you encourage them when you see good, positive behaviour, and how you also have the ability to pick them up when they're not doing something which is right. And that's a difficult discussion, but it's something that I've always respected when someone that I respect has told me to change my behaviour slightly.
So it sounds like you had military experience and then you had fellowship experience with good mentors. How did you carry on there to come to where you are today?
So then I came back to New Zealand and worked at the Starship Children's Hospital where I am and in private practice. And then I saw what the association, the New Zealand Orthopaedic Association, had given me. And I've always been someone who I think find it very important to give back. And certainly I was brought up to that the more you put into something, the more you get out of it. So in 2002, I did the ABC Travelling Fellowship, and really it just went from there. When I really have wanted to serve the New Zealand Orthopaedic Association as much as I can. I then became a member of the Education Committee. I then was elected onto the council of the NZOA. I then had a little bit of time out from that. I've been busy. I've got 4 children as well, and I think it's important to balance your home life with that as much as you can. And then I was lucky to be approached to consider becoming the president of the New Zealand Orthopaedic Association, which, to be honest, I thought was a little bit early in my career to do that at 56. But I'm not someone to ever give up an opportunity to do something, and I think if you're asked to serve, then the important thing is to serve and do your best when you can.
That's a great lesson in leadership, is just taking advantage of the opportunities that present themselves.
I think so, but I think you also got to look at your life. I think you need to work out what you want to do, and you need to balance that with what else is happening in your life. So it's very important to consider your family, if you have a family, or your wider family, or other things in your life. It's that real balance between being selfish and serving. And I think things have changed over the years. I think if I look at some of my forebears, I think they probably served too much and they spent too much time doing that. And I think, the younger generation are criticised now, but I think they've actually got a better balance than what we have had. And I think the pendulum's somewhere in between. And but yeah, think before you serve, but please realise that the more you give, the more you'll get out of an organisation.
Yeah, well, thank you for those words of wisdom. So the AOA is committed to identifying and discussing critical issues in orthopedic surgery, and I'm interested in the critical issues that are present in New Zealand. What do you see as the critical issues facing the New Zealand Orthopaedic Association at this time?
I think our critical issues really are in providing orthopaedic services to our patients, and look, we were behind in doing that before COVID came. COVID has amplified that problem, and we haven't actually got back to pre-COVID levels of providing that level of care in our public system in New Zealand. Why has that happened? Well, we've lost a lot of our workforce for a number of reasons, and we're really struggling to fill that workforce. Secondly, we're doing a lot more trauma surgery within the public hospitals now, so our elective surgery has dropped off a lot. And to be honest, I think there's just been a little bit of disillusionment and lack of work ethic by our health authority and the hospitals, and actually trying to get through work. So what that's led on to is our residents are not getting as much elective training as they used to get. So we're really dropping off in the amount of elective surgery that they've been exposed to, which is a concern for our training. And the third thing, which I think is just everywhere in the world, and I don't think we'll ever cure it, is we need more money to provide health care to the level that we want. So in terms of how to address those challenges, I think we need to rationalise what we do. We need to get better at our processes. So there's no point asking for extra resources when you actually haven't got your efficiency and processes working well. So I think we need to really look at how we do things efficiently. We need to motivate people to get involved. And I think with that, it'll cure some of our problems. But I'm not sure how much more money we can print, but we certainly need more of that.
So I think obviously the pandemic was a global event, and so that's something that all of our countries share and that orthopedic surgery has seen worldwide. You mentioned that you have a lost workforce.
Yeah.
Is that a lack of engagement? Is that monetary? What is that across all allied health professionals and physicians, or what's the situation in New Zealand?
So it seems to be right across the board. So I think even though New Zealand, we're known as Kiwis. If you don't know what a Kiwi is, it's a flightless bird, but in fact we're a country that actually spend more time in aeroplanes than any other country in the world. We're the great explorers. So we always love to spend time abroad and travelling, and that's part of the Kiwi psyche. So I think a lot of people are taking the opportunity to travel now. A lot of the junior doctors are going, right, we're going for our 1 or 2 years abroad, so they're leaving. In terms of allied health professionals, I think they really worked hard during the pandemic, and they've just said enough's enough, and maybe some of the older staff and that have retired or gone on to other jobs. Basically, the workforce in New Zealand across all jobs is low. So in fact, people can leave health and go and work in other jobs and actually get paid more, less stressful, bit of a change in life, and do that. In terms of around the world, Australia, for example, offer a lot more money for nurses, better conditions, and a cheaper living over there. So there has been a lot of people leave to go to Australia. And unfortunately, our government has really been slow in opening the doors for immigration. So we're competing with the rest of the world for allied health professionals and doctors. And unfortunately, even though it's a pretty amazing country to live in, we just financially can't offer what other countries are doing.
And what is the present status of the workforce for orthopedic surgery?
So that's a really good question. At the moment, we can employ most of the trainees that we put through our system. However,
About how many graduate every year through your?
Approximately 15 to 20 at the moment. And some will go and work overseas, but the majority will stay in New Zealand. And the majority, or almost all our trainees, want to work both within our public health system and work in our private system at the same time. Their major concern for trainees at the moment is, one, is the training, getting enough elective surgery, but secondly, getting a job at the end of their training. And I think we have to start being creative in how we do that. I think we need to look within our departments as how we can create jobs for them, but also our public health system or government needs to create a bigger infrastructure so that we can actually accommodate them with operating time, clinic time, etc. So that's a real challenge for us, and it certainly is the major concern of the trainees is employment when they're finished.
And just because we don't have the public and private system quite as much in the United States, could you just review a little bit for us the situation in New Zealand? Are the majority of orthopedic surgeons public or private or combo? How does that pan out?
So the majority of orthopedic surgeons are a combination of working both in public practice and private practice, and that can vary from working maybe 40% in public up to 60% in public and the rest in private practice. That's in separate hospitals. The public hospital is a salary from the government. The private practice is very similar to the United States, with insurance companies paying for the services. And that seems to be a nice combination that gives people a lifestyle and an income which is commensurate with the amount of work they've done and what they've put into it. The majority, as I say, almost all residents want to work in that dual system rather than one or the other. Unfortunately, at the moment, there are not enough positions within the public system, so some of our residents end up graduating, doing a fellowship for 1 or usually 2 years, and then they come back and work full-time in the private practice in the bigger towns, for example in Auckland or Christchurch or Wellington, rather than getting a public position. But that's usually not what they've chosen to do, but just what they've had to do.
Mm-hmm. So as you're speaking about training, maybe we could talk a little bit more about the training of the next generation in New Zealand. We have many leaders in the AOA that are committed to educating competent orthopedic surgeons, and we're just rolling out competency-based medical education across the United States. Can you tell us a little bit about your training program in New Zealand, and then what your experience is with competency-based medical education?
So our training program is a 5-year training program. For someone to get onto our training program, they would have spent 5 years as a doctor, having left medical school before they enter that training program. 3 years of that would be as a resident doing surgical specialties but without being on the training program. So by the time they get to becoming a PGY1 on our training program, they would be very competent in treating a long bone fracture with an intramedullary rod, fix an ankle fracture, do a DHS and a hip fracture, and be able to do some limited upper limb surgery. So they're at a level which may be around a PGY 2 or 3 on your system in the United States.
So just to repeat that again to make sure that I have it clear. So your medical school is included in your university?
Yes. So
and that's how many years?
So our medical school is 6 years, of which the 6th year is called an intern year, where it's full-time in the hospital. But then you graduate with a medical degree after the 6 years. You then spend 2 years as a house surgeon, which is an English term for where you're just working under residents in a hospital, doing what you used to call in the United States the scud work for the more senior doctors. And then you, after those 2 years, you get onto what's called a non-training position as a resident, where you rotate through surgical specialties, working with a consultant surgeon, doing some surgery, assisting with surgery, getting your references together, your research together, your references from who you work for before you apply for our training program. And so the process from having finished 6 years as a medical student is 5 years as a non-trainee doctor, followed by 5 years on the training program, followed by a minimum of 1 year, usually 2 years of a fellowship, which is generally overseas.
So it sounds like this 5 years that's between medical school and the training program really provides a lot of experience in the core areas of orthopedics, and that they arrive, So it sounds like the 5 years of between medical school and when they start the orthopedic surgery training program really provides a lot of the core knowledge, both in surgery and in orthopedic surgery. So they come to your door with a fairly strong basis in the core portions of orthopedic surgery.
Yeah, I wouldn't say they're really trained. It's not an organised education program in that 5 years. So a lot of that will be self-learning, reading around cases, coming along to the training program, lectures which you're allowed to come to. But it's not really a structured program for them. And to be honest, I think it's something we really need to address in New Zealand and become more like the North American model of leaving medical school and going into a residency training program. I think the advantage of spending some years after medical school and before going into a training program gives you the ability to look at some different areas that you may want to get involved in. However, I think delaying it 5 years really alters your timeline in life as to where you're heading. And I think increasingly as more women have got into medical school, more women are specialising, that's a 5 years which I think is delaying their ability to have a family. If they potentially want to have a family, I think they're finishing too late in their training, often in their mid-30s before they're actually getting a consultant position. And so what I really encourage people to look at is their timeline in life and to really work out what they want to do and where their training fits into that. And they need to make decisions, the resident needs to make decisions to what they want to do. And I really would like to try and get that 5 years down to 1 or 2 years, more like the North American model.
So tell me a little bit about the training program itself, and do you have some structure regarding specific competency-based for their graduate medical education?
So we have a very structured training program. It's a 5-year program. It's a national training program. This involves really an apprenticeship model at the moment where you do a 6-month rotation and then you move on to another one. You spend 2 to 3 years in a major centre or teaching hospital. You then also spend 2 years in the peripheral hospitals. This is for a number of reasons, as we have extremely talented surgeons in all those different places, but also encourages people and hopefully generates an interest that they may want to go back to a more rural hospital eventually when they graduate. In terms of competency-based training, we are very attached with the Australian Orthopaedic Association and how we run our trainees. We have a system whereby they have to do certain modules every rotation and a system called TIMS, whereby we objectively measure how they're doing by sitting down with them, watching them do an examination, tick them off on doing that examination, tick them off on the number of cases they're doing, and they have to report that back to the training committee every 6 months. Certainly the challenge going forward is we do want to adopt a competency-based training program because we feel that there's areas at the moment where they're really missing in their training and it's hard to monitor that. The challenge is how we institute that. And personally, I think we're going to end up with both an apprenticeship type model with a competency-based model as well, with modules whereby both the resident and the trainee supervisors can look objectively at what the trainees achieved, the level of competency they've achieved. But also, I think it's really important, as I mentioned earlier, about mentoring, that you do actually spend time with people really learning how they're thinking. How is your trainer, how's your boss, how do they think, how have they become where they've got to, how they manage patients, how they communicate with them, how they decide whether they need surgery or not, which I think is the most important thing in orthopaedic surgery. And you don't learn that from a book, you don't learn that in the operating room, you learn that in the clinic. So I think it's going to be a combination of both eventually.
Yeah. And certainly that surgical judgment is not only difficult to teach, it's also difficult to measure.
Absolutely. And managing residents is challenging. Managing the resident who's underachieving is difficult. And I don't think they're always necessarily underachieving. I think they're sometimes misunderstood. But it's how you manage that and how do you grade someone's thought process? I don't know, but that's something we really have to try and figure out.
You mentioned TIMS. What is TIMS?
TIMS is a computer-based program which the Australian Orthopaedic Association developed. It's a system whereby these modules or learning processes are in place that both the consultant surgeons and the residents have, that we log on to. We do it all online. We write comments. We basically not examine, but somehow objectify their training and and that directly goes back to the directors of training so they can see how their trainees are doing. So it's a very structured online learning system with feedback that the residents, make us do. If the residents don't do this during their 6 months, they can be held up in their training for not doing it. Interestingly, one of the challenges is actually getting the surgeons to actually get involved and do it. And, that's something I think if you commit to training as a surgeon, it is a big commitment and it's a very important commitment to do. And so if you're not prepared to do that, you should opt out. And I think it's going to become more intensive the way we train with competency-based training. I think you're going to have to be more involved. So I think you need to learn how to be a good teacher and actually spend time doing the assessments.
Do you think these assessments have been helpful? So, for example, you as the assessor, do you think you can be honest, you can provide good feedback, and then as the learner, do you think that there's receptivity to that feedback? I mean, how do you make that whole assessment feedback cycle work?
Yeah, I think that's a really good question because, I think if I look at it in general, and maybe even look at myself, it's really hard to sit down and tell someone honestly that they're not doing quite as well as they should be. It's much easier to say, wow, you're doing well. Mm-hmm. And I think when it comes to the end of a rotation, it's much easier just to say, yes, you've passed rather than no, you've failed.
Yeah.
Because, man, that takes a lot of paperwork and meetings after that. So it's how you stimulate that to change. And I remember when I was on the training program, we had some examples of people finishing their 6 months and then some grumpy old surgeon saying this person's failed. And, man, that just wrecked my next 6 months because I was having to manage these people. But you can't do that. You can't do that in a job. If you don't think your secretary's performing, you can't just tell them you're fired.
Yeah.
And so what we thought we brought in then was these 3-month assessments where halfway through the rotation you had this feedback, and if there was something that the resident was slightly not as proficient as they should be, and you could give them that feedback, and then the next 3 months try and improve that, and then finish at the end of 6 months to give them a clear pass. Adult education, I really hate the term saying pass, fail. I mean, we're adults, and you see in our system, we're with 30-year-old people who are still in training, and I think adult education is more about having that conversation and really helping someone. It's not a pass, fail. Everyone who's a resident should complete the scheme.
Yeah.
So it's not a matter of getting them over 50%. We want to make them all 100%.
Well, and we want excellence in our field.
We want
a profession that, number one, is professional,
yeah,
and number two, provides excellent patient care. And so how do you raise that bar? I mean, we don't want to just have the lowest bar possible and make sure that they, roll over the finish line.
And that's where I think competency-based training is good, in that it forces the resident and the consultant surgeon to sit down together and actually have to discuss different parts of that competency on a one-on-one basis. And I think that any time that you can bring those two people together to discuss that is going to be a positive thing rather than not discussing it formally. So it'll depend on the interpersonal relationship between a consultant and the resident, but I think it's something we really need to work on, yeah.
Thank you, Haemish, for joining me today for this conversation. I think your leadership journey and the experience that you have told us about in New Zealand really helps broaden the mindset of our AOA members and hopefully allows greater appreciation of the diversity of orthopedic surgery across the world. It's really been my privilege to spend time with you discussing these important issues. So thanks for coming.
Oh, thanks, Anne. And, it's been wonderful spending time with you and your husband, Greg, on the carousel. And I think the more that we can share what we do to enhance patient care and satisfaction as orthopaedic surgeons, then I think it's a wonderful thing. So thanks for having me. And, in New Zealand, we really appreciate having the involvement with the American Orthopaedic Association and everything it stands for. And we really want our ongoing relationship with that to just continue to grow and improve. And thanks very much.